Now coming to the primum atrioseptal defect, that is the defect of the atrioventricular septum, that is septum intermedium. When the septum intermedium is not being formed, the septum primum will not be able to approximate to the septum intermedium when it is not there itself, and the ventricular foramen will be persistent because the part of the ventricular septum is contributed by the septum intermedium, the dorsal endocardial cushion, in other words, the right half of the septum intermedium, we said. So there will be an atrial septal defect as well as the ventricular septal defect. So that is what is called as a spectrum of atrioventricular septal defects, wherein both the atrial and the ventricular septal defects are seen. So this is how a normal interatrial septum is seen with foramen ovale. After the formation, the foramen ovale is closed where you have fossa ovalis here. So this is what is the septum primum if it is more resorpted than what is needed. The septum secundum can't grow to that effect to cover up the cranial end of the septum primum. So there is a atrial septal defect. This is how it is seen. The septum secundum is there and there is more resorption of the septum primum. There is a very short septum primum where the septum secundum will not be able to cross the cranial end. The cranial end of the septum primum has to be crossed by the septum secundum to have a oval fissure like thing. It is foramen ovale. So here it is a larger foramen that is seen, and here there is absence of septum secundum totally, and here it is the absence of septum primum as well as septum secundum. That means the interatrial septum, atrial septum itself is totally absent, which has a common atrial chamber. Now coming to the defects of atrioventricular canal. That means first one is persistent AV canal, wherein the endocardial cushions fail to fuse to form the septum intermedium. So there is this atrial septal defect as well as the ventricular septal defect, because both has to approximate onto the septum intermedium for their closure, which doesn't happen because septum intermedium itself has not formed. So there is shunting of blood that is seen from left to right initially, and then after some time and after the blood which is received from the superior inferior vena cavas, then there is right to left shunt. So initially, because of the oxygenated blood that is received in the atrium, the pressure here is more than the right. That is the reason there is closure of the foramen ovale, right? So the blood from the left, it shunts to the right, and because of the blood, the deoxygenated blood which has come from superior inferior vena cava into the right atrium, so there is a right to left shunt as well. So that is what will happen. And the next one is the tricuspid atrasia. So here what happens, you can see there is only two leaflets that are seen. So there is abnormal valve formation also, atrioventricular canal. There is a one-way atrioventricular canal. So the endocardial cushions. These leaf valves are formed from right and left endocardial cushions. The ventral and dorsal endocardial cushions will fuse to form the septum intermedium. So the right and left will form the valve. So we do not have the septal valve or the medial valve for the mitral and the tricuspid valves. So there is abnormality in the valve formation also. So tricuspid atresia is, there is no patency or the communication between the right atrium to the right ventricle. So there is obliteration of the right atrioventricular canal. So there is, the atresia is because of the atresia of the tricuspid valve will cause this. Then what happens is, with the atresia, there is no tricuspid valve only that is being formed, isn't it? So when the blood is being poured from superior and inferior vena cava, where the blood will flow, it has to flow only into the left atrium, because the right ventricle, there is no access because of the tricuspid atresia, isn't it? So then there will be patent foramen ovale, right? But what happens, there is formation of pulmonary trunk and the aorta. So this is also associated with ventricular septal defect, wherein the blood flows from left ventricle into the right ventricle and then into the pulmonary trunk. And there is overdeveloped left ventricle because more work is being put up. It is to flush blood through the aorta as well as to the pulmonary trunk. And there is underdeveloped right ventricle because there is absolutely no flow of blood from right atrium to the right ventricle. Normally from right atrium it has to go to the right ventricle and then to the pulmonary trunk. But since there is no proper functioning of the right ventricle, we said that the ventricles are formed by the hemodynamic changes of the blood flow. When the blood flow itself is not there into the right ventricle here, so naturally there won't be any development of the right ventricle that is seen. Coming to the defects of interventricular septum. So as we said, the interventricular septum has two parts, the muscular part and the membranous part. So there can be defect in the muscular part, there can be defect in the membranous part because they are all developed from two different sources. So if the muscular part has a defect, then the blood flow, the shunt is bidirectional. It flows from the right to left and from left to right as well. So there can be a single perforation or multiple perforations in the muscular ventricular septum. And this is usually seen caudal to the interventricular septum. If the ventricular septal defect is seen in the cranial part of the ventricle, that would be the muscular membranous ventricular septal defect, which can be because of the failure of the contribution by the bulbar septum or by the septum intermedium, the proliferation of the septum intermedium. So because of that deficiency, the membranous part of the septum can have a foramen wherein the shunt will be from left to the right. So these shunts can be corrected by putting a foreign device via the femoral vein, via the common iliac and then inferior vena cava into the right atrium and then the right ventricle. That's how the mesh is being put here, closing the foramen tightly. That's how the septal defects are being corrected surgically, non-invasive. There can be a common ventricle-like common atrium, which is also called as trilocular biatrial. This is, so you have two atria here, but a common ventricle, but there are three chambers. So trilocular biatrial. If there is single atrium with two ventricles, it is called as trilocular biventricular. So here again there is a mixing of oxygenated and deoxygenated blood, and there is deficiency and differences in the systemic and the pulmonary circulation and all that, which will lead to other major problematic conditions. Next is coming to the muscular septal defect only, which is called as Eisenmenger's syndrome, where you will seeing the shunt reversal, which is also called as shunt reversal syndrome also. So what so happens here is, because of the ventricular defect, the blood from the left ventricle also comes on to the right ventricle, and then it passes on to the pulmonary trunk. So there is more work that has been done by the pulmonary trunk and the pulmonary artery. So there is thickening, hypertrophy of the wall of the pulmonary artery, leading to pulmonary hypertension, because more pressure is needed here to pump blood to the lungs. So the lungs receive less amount of blood than normal for oxygenation. So after the oxygenation, the blood is again circulated to the left atrium, which is of less quantity than required because of the pulmonary artery hypertension. So that will cause cyanosis, bluing of the extremities, because of the legs oxygenated blood that is being circulated, which is usually seen in Down syndrome, and this is more so seen in about 6 months. So that's how it happens, wherein more of the blood which is flowing from the right atrium to the right ventricle is shunted to the left ventricle and enters through the aorta and into the systemic circulation, causing cyanosis, because there's a lot of deoxygenated blood that is being mixed with the oxygenated blood, which is called as acquired cyanotic heart disease, where the shunt is from right to left. So it's a very poor prognosis that is seen. They can do the heart-lung transplantation, can be done, because there is dilatation of the infundibulum of the pulmonary trunk and the hypertrophy of the pulmonary artery. So the systemic to the pulmonary circulation connection will be seen, and the left to right shunting of the blood is seen. An increased pulmonary blood flow is seen, which will cause the hypertrophy of the pulmonary artery because of the workload, and irreversible pulmonary vascular injury. This one, it is not reversible, and stunting also cannot cure this. So there is irreversible pulmonary vascular resistance as well. So the right to left shunting of the blood is seen, where leads to hypoxia because more of deoxygenated blood is being mixed with the oxygenated blood and is supplied to the other parts of the body. And then coming to the defects of aortopulmonary septum, which is dividing the conus cordis and the truncus arteriosus into pulmonary trunk and the aorta. So persistent truncus arteriosus, that means due to failure of the development of spiral pulmonary aortopulmonary septum, the truncus arteriosus overrides the interventricular septum and receives blood from both the ventricles. Because this aortopulmonary septum is not formed properly, so the contribution by the bulbar part to the membranous part of the interventricular septum is deficient. So there is persistent of the interventricular foramen, which means that there is an interventricular septal defect. So from both the ventricles the blood is flown into the truncus arteriosus because it is not divided into two trunks. The pulmonary trunk and aorta are not yet divided in the proximal part. But later on the septum has been formed and the pulmonary artery and aorta are divided. But as there is admixture of the blood from the right atrium, right ventricle and both the ventricles, they supply and circulate blood into the proximal part of the truncus arteriosus, that is into the infundibular part, and the aortic vestibule are not separated. So there is a common trunk here, but at the truncus arteriosus level it has been separated. So there is the persistent truncus arteriosus that is seen. So that takes the more of deoxygenated blood to the systemic circulation as well. And then tetralogy of Fallot we will see in the next slide more detailedly. And congenital aortic valve stenosis, this one. So when there is aortic valve stenosis or aortic atresia, this can be due to fusion of the cusps of aortic valve leading into narrow aortic orifice. So the left ventricle you can see is hypertrophied because of the more pressure it has to exert to flush blood into the aorta, and because of the less amount of blood that is being flushed into the aorta and to the systemic circulation, the blood that is being flushed through the pulmonary trunk also circulates through the arch of aorta and descending aorta by patent ductus arteriosus. So when aortic atresia is seen, there is patent ductus arteriosus that is seen. So here it is the stenosis, where the narrowing of the valve is seen. So there is hypertrophy of the left ventricle, and there can be atresia where the pumping of the blood is not there only. So from the pulmonary trunk only, the blood via the ductus arteriosus is pumped to the aorta, which is deoxygenated blood, so which carries danger of survival. Coming to the, here you can see very clearly the persistent truncus arteriosus proximally, whereas distally it is being divided into aorta and pulmonary trunk. But proximally it is not differentiated into vestibule and aortic part, the one which is opening into the left atrium, aortic vestibule. And then let's come to this. So this is the pulmonary atresia, where the blood from the right ventricle cannot flush pump its blood into the pulmonary trunk because of the atresia of the pulmonary valve here. So the blood from the atrium, as it flushes to the ventricle, it regurgitates back into the right atrium and is pumped into the left atrium, left ventricle, and into the pulmonary circulation. So there is again a mixture of deoxygenated to the oxygenated blood. And here it is the transposition of the great vessels, where the spiraling of the aortopulmonary septum, if it doesn't happen, both the vessels are aligned parallelly on one side, side by side. So that is what is transposition of the great vessels. And here in this condition, the only access through to the lungs is by the patent ductus arteriosus. Okay, here, so the pulmonary trunk here receives the oxygenated blood, and the aorta will be receiving the deoxygenated blood. So that's how there is a lot of difference in the circulation that happens with the transposition of great vessels when there is no spiraling of the aortopulmonary septum that happens. There can be a double chamber in the right ventricle where the extra valve like thing that can be formed within the right ventricle, having a smaller chamber here and a larger chamber here, which is called as double chamber of the right ventricle. There is a condition which is called as Epstein's anomaly, where the tricuspid valve is displaced much lower caudally. That means the membranous septum is pulled more during the development, where the septal leaflet is much displaced downwards, so that to have a proper valve and the cusps oriented, the anterior leaflet is very much expanded or elongated, abnormally positioned than normal. So there is hardly a place of the ventricle. There is a very, very large right atrium that is seen. So there is that's how the flow into the pulmonary trunk will be mostly from the atrium itself, because the ventricle is much lower because of the atrioventricular valve, which is at much lower end. Caudally it is displaced because of the displacement of the atrioventricular valve much caudally. So to compensate this, there is a very much enlargement of the right atrium and the right ventricle that is seen. So there is regurgitation of the blood that is seen from the right ventricle into the right atrium, and then the blood is flushed to the pulmonary artery. So that is what is Epstein's anomaly. And hypoplastic left heart syndrome is because of the atresia of the aortic valve, where there is no proper flushing of blood from the ventricle into the atrium. So the blood from the left atrium hardly flushed into the left ventricle, so there is hardly any development of the left ventricle. So there is very much hypertrophy of the left ventricular wall, or the hypoplasty of the left ventricle is seen. Yeah, this is what is tetralogy of Fallot, which can be asked as a clinical question for you. So it has 4 features. Number 1 is a very large ventricular septal defect. and there is overriding of aorta that is seen, and infundibular pulmonary stenosis, that is at the conus cordis. It is not the stenosis of the pulmonary valve, it is the infundibular part of the pulmonary trunk that has stenosis, and right ventricular hypertrophy because of more work that has to be put up by the right ventricle. So with all these features, when an X-ray is being taken, this is a normal X-ray. So when an X-ray of the tetralogy of phallic person is taken, there is hypertrophy, of the right ventricle that will be seen, and the overriding here of the aorta that can be seen, which gives the heart a boot-shaped structure. Boot-shaped heart it is called as. So it is Conner-Sabot is the name that is given to this. So this is the finding that can be seen in the tetralogy of phallic. This is how the normal heart that is seen, because there is no bulging of the right atrium that is seen, but with the hypertrophy of the right ventricle, there is bulging of the right side of right border of the heart, we can say, which is formed by the right atrium, isn't it? So that is seen very much bulged onto the side. So that can be, as said, can be corrected by the pericardium. You can use pericardium to correct the structures or any of these patches what we have seen, and there is resection of the ventricular wall also is done to correct the features of the tetralogy of phallic. So all this is about the tetralogy of phallic, where the 4 features which are very important are seen as the ventricular septal defect, overriding of the aorta, because there is right to left shunt because of the presence of the ventricular septal defect, and infundibular pulmonary stenosis. Because of this feature also, the blood is pumped onto the left side, because there is no proper flow of blood into the pulmonary trunk because of the infundibular pulmonary stenosis. Most of the blood is pumped onto the aorta, and then because of this pressure that has been increased in the right ventricle because of the pulmonary stenosis, there is right ventricular hypertrophy. So all these things are about the tetralogy of phallic. And then coming to the abnormal positions of the heart. If the looping of the heart itself is not proper, then there is dextrocardia. So normally the heart is on to the left side. Here in dextrocardia, heart is on right side, heart is right. So there can be only dextrocardia that is seen. So only the heart itself is on to the opposite side. So the left side heart will be on the right side because of the abnormal looping that happens in the heart during its development. But there is a condition which is called as situs inversus totalis, where dextrocardia is seen along with situs inversus. That means all the organs are inversed, they are reflected onto the opposite side. So the right lung will be on the left side, the left lung is on the right side, and the left heart will be on the right side. The heart, the apex of the heart which is on the right, most of the heart is on the left part of the thorax, isn't it? So here it is on the right side. All organs are in their opposite directions. Say arch of aorta, which has to arch onto the left side, it arches onto the right side, and the liver, which is on the right side, will be on the left. Stomach is on the right side. Spleen will be on the right side. Appendix is on the left side. Ascending colon. Everything is a mirror image, which is seen in the situs inversus. So when it is associated with dextrocardia, it is called as situs inversus totalis. The only dextrocardia, if it is present without involvement of any of the other organs, it is just called as the isolated dextrocardia or dextrocardia itself. So as said, the management of all these repairing procedures of the septum and the stenosis and all that can be an open heart surgery or non-invasive catheter directed, which is what is followed mostly now. So in open heart surgery, the pericardium or the synthetic material is used to close the opening like this. Whereas when it is catheter directed, it is only the synthetic material. So it will be directed by the catheter, and then the synthetic material will be opened up and the catheter will be withdrawn, where the synthetic material will be closing over the opening tightly. So that's how the septal defects are treated. Yeah, these are the people who have the situs inversus totalis, wherein the body function, nothing happens wrong with the body function. There is nothing that pathologically that can be experienced by those people, where I think you're all very much familiar with this person, Enrique, who is a singer and a lyricist, who is known as King of Latin Pop. These American song shows and all, he is now appearing as a, the judge, I believe. She, I think, is also a very familiar character. It's Catherine O'Hara, who is seen mostly in, very much known in Home Alone series. She is a Canadian American actress, writer, comedian, director, everything she is. So she is one person, and he is a football player in National Football Academy, Randy Foy, who is also having a situs inversus and still having a sport like this. So there is nothing grossly that can be seen in persons who are having situs inversus. Nothing can be detected also, which is seen in Rosemary Bentley, who lived for 99 years, and she donated her body after the demise to the Oregon Health and Science University, where during the dissection they found that there is situs inversus that is seen in this lady. So that's how the situs inversus does no harm. It is just the mirror image of the organs of one side to the other side. The right organs are placed on the left side and the left organs are placed on the right side, and the function is absolutely normal. So these are all the celebrities who have this sort of anomaly.